Hello. First of all, I'm honored to welcome you to LAMSA's third webinar. Today's topic is drugs use and suicide. And I'm going to be presenting. I'm Mona Abu Sleiman, a medical student here in Paris and a LAMSA ambassador for this cycle. So, first of all, I wanted to ask, why do people take drugs? Does anyone have anything to say to why do people take drugs?
To forget about their worries.
Yes, they do take drugs to relax and feel better. What else? To cope, to fit in. To escape problems. Okay. Yes, to relax. Okay, so for the experience also, it's true. So first of all, people take drugs to feel good. Drugs can produce intense feelings of pleasure. This initial euphoria is followed by other effects, which differ with the type of drug used. For example, with stimulants such as cocaine, the high is followed by feelings of power, self-confidence, and increased energy. In contrast, the euphoria caused by opioids such as heroin is followed by feelings of relaxation and satisfaction. Second of all, as you said, people take drugs to feel better. Some people who suffer from social anxiety, stress, and depression start using drugs to try to feel less anxious. Stress can play a major role in starting and continuing drug use, as well as relapse, so return to drug use, in patients recovering from addiction. Third of all, people take drugs to do better. Some people feel pressure to improve their focus in school or at work, or their abilities in sports. This can play a role in trying or continuing to use drugs, such as prescription stimulants or cocaine. And finally, as you said, people use drugs for curiosity, for the experience, and also due to social pressure. In this respect, teens are particularly at risk because peer pressure can be very strong. Adolescence is a development period during which the presence of risk factors such as peers who use drugs may lead to substance use. So you're going to be asking, if taking drugs make people feel good or better, what's the problem? So where's the problem in taking drugs? First of all, when the people first use a drug, the people may perceive what seem to be positive effects. So they're just like in the good state. And they may also believe they can control their use. They're going to tell you, no, it's just occasionally, it's just to feel better sometimes. I'm not going to use it regularly. But drugs can quickly take over a person's life. Over time, if drug use continues, other pleasurable activities become less pleasurable, and the person has to take the drug just to feel normal. There's something that, a symptom that we call anhedonia in psychiatry. It's the loss of pleasure and joy in doing something that you used to love to do. For example, like someone who likes to read books during his free time. He's going to lose this pleasure in reading books. And this is a symptom of depression. So people will have a hard time controlling their need to take drugs, even though it causes many problems for themselves and their loved ones. Some people may start to feel the need to take more of a drug or take it more often, even in the early stages of their drug use. These are the signs of an addiction. Now, the consistent use of alcohol and drugs can create a variety of problems, from low quality of life to legal issues to overdose. And there are many life-changing consequences that someone that is suffering from substance abuse may go through. And another significant risk involved with substance abuse, often overlooked by loved ones and even treatment centers, is suicide or the deliberate ending of one's own life. Now, let's talk about substance use and suicide in numbers. Worldwide, more than 1 million people commit suicide every year. Those with alcohol use disorders are almost 10 times more likely to die by suicide compared to the general population. Those who inject drugs are about 14 times more likely to commit suicide compared to the general population. 58% of all admissions for suicide were associated with drug and alcohol addiction. So the number is huge, it's more than half of admissions for suicide. And 25% of alcoholics and drug addicts kill themselves by a variety of means. There's a lifetime prevalence of 18% for suicide among alcoholics and drug addicts in the general population. And 70% of adolescent suicide are associated with alcohol and drug problems. Usually, males outnumber female suicide victims by almost 4 to 1, but the association of suicide with substance use disorder in women is markedly stronger. Up to 30% of patients seeking treatment for substance dependence report a history of suicide attempts. Why is that? Why do they report a history of suicide attempts and they are actually seeking treatment? It's because substance-dependent individuals entering into treatment are at elevated risk for suicide attempts for various reasons. They often enter with depressive symptoms and a number of severe stressors, relationship loss, job loss, health and financial problems, that not only impel them to seek treatment, but also put them at higher risk for suicidal behavior. And these stressors that we mentioned are the same stressors that are caused by drug use sometimes and drug addiction. Now, the association of alcohol and drugs with suicidal thinking and behavior is both causal and conductive. Alcohol and drug addiction are major risk factors for suicide, both as direct causes and as precipitants for suicidal behavior. The chronic use of alcohol and drugs play a primary etiologic role in the emergence of suicidal thinking and actions via pharmacological effects on the brain that impair judgment and cognition, so you can think clearly, and cause severe depression. The crisis-oriented lifestyle of the alcoholic and drug addict, with subsequent disruption of interpersonal relationships, is conducive to the development of suicidal impulses. What's very important to know is that the subjective state of hopelessness is key to the disposition to actual suicide. Hopelessness is the imminent feeling that appears to precipitate self-inflicted destruction. It correlates highly with suicide and is central to the suicidal state, whether drug-induced or from some other cause. The mind apparently requires hope not only to sustain sufficient mental inertia for survival, but also to avoid self-extinction. Alcohol and drugs are influential in providing this feeling of hopelessness by their toxic effects, by disruption of interpersonal relationships, and social supports, and possibly by manipulating neurotransmitters responsible for mood and judgment. Because alcoholism and drug addiction are leading risk factors for suicide and suicidal behavior, any alcoholic or drug addict should be assessed for suicide, especially if actively using alcohol or drugs. The presence of comorbid psychiatric disorders among the chemically addicted is associated with a greater prevalence of suicide. So the alcoholic and drug addict may have comorbid psychiatry disorders that also have suicide as a significant risk factor. So it's always important to see if the person have other psychiatric disorders that may interfere, where alcohol and drug addiction may interfere. So the most common comorbid psychiatric syndromes are depression, borderline personality disorder, mania, and schizophrenia. Also, a family history of depression, suicide, and alcoholism were prominent in suicide cases. There are many types of drugs that are associated with suicidal behavior, such as depressants, particularly alcohol, sedative and hypnotics, opiates, stimulants such as cocaine and amphetamines. And these drugs are especially likely to produce a sense of hopelessness, which is key to actual suicide. So the pharmacological actions of these drugs induce a depression that is similar to depressions from other causes. They are characterized by depressed mood, a psychomotor retardation, a social withdrawal, guilt, and self-reproach. Depressants tend to produce depression during intoxication, whereas stimulants usually produce depression during withdrawal, so once the effect is over. These drugs of addiction provide a neuropsychopharmacologic model for depression and suicide, and may provide insights into mechanism underlying suicidal behavior. Now, in conclusion, we're going to talk about the treatment. The comorbid depression derived from alcohol and drug use will gradually diminish during abstinence. In the alcoholic and drug addict, the depression, paranoia, and anxiety are usually induced by alcohol and drugs, and abstinence from alcohol and drug is essential. However, the tendency for relapse among alcoholics and drug addicts is high, and specific treatment of the addiction must be instituted. Generally, hopefulness reappears with prolonged abstinence if specific treatment of the addiction is implemented. The suicidal thinking and behavior usually dramatically diminish with abstinence and treatment of addiction. They may persist, however, during the early months at chronic lower levels because of prolonged pharmacologic effects of the drugs. And the degenerated state of the personality and the impaired mental state of the addicted individual play prominent roles. Because most of these factors respond to treatment, the suicide risk is low for most alcoholics and drug addicts in early recovery, despite the recurring suicidal thoughts. Pharmacotherapy with antidepressant and antipsychotics is not indicated in the majority of cases of chemically induced depression, and may actually be harmful in a population vulnerable to drug effects such as sedation, reduced cognition, and altered mood. However, for those instances where imminent dangerous level of suicidal thinking may persist, the selective use of antidepressants should be instituted. Finally, careful screening for the diagnosis of alcoholism and drug addiction is of critical importance in setting in the setting of a suicide attempt. Unless alcoholism and drug addiction are identified as etiologic or precipitating agents in the suicide attempt and are properly treated, the likelihood for another suicide attempt is high. If only specific treatment for the comorbid psychiatric syndromes are initiated, the sense of hopelessness will persist, as well the serious risk for suicide. There's an important thing that it's the most important thing that you always need to check when talking to a patient who just had a suicide attempt, or actually any psychiatric patient. We always need to ask about alcohol use and drug use. It's essential. I was a psychiatric extern last month, and there's literally there's not a consultation where we didn't ask about alcohol use and substance use. Why? Because alcohol and drugs, as we said, will have an effect in the neurotransmitters in the brain, and they will alter the the normal functionment of these neurotransmitters. And this functionment, once it's altered, it may cause depression, which may lead to suicide. And a very important thing, for example, is that one of the most important risk factors for schizophrenia is cocaine. So it's primordial, literally, to always ask about drug use and alcohol use, and the patient may not always tell you the truth. So you need to dig deeper to ask the family, friends about his usual activities. So that's it. I'm here if you have any questions. Thank you for watching. I guess no one has any question. Thank you. I'm gonna end the meeting.